I apologize. But I am so happy to have Robert Greifinger, Bob, and Michelle Staples Horne. Michelle are both friends of mine from, well, for a long time, and colleagues. I'm so glad to be able to have been associated with these good people for pretty much my entire career in correctional medicine. Bob is a fellow of the American College of Correctional Physicians. Michelle has been president. Both have been awarded the top award in correctional medicine, the Armin Start Award, with very good reason. Bob wrote the book on public health and correctional medicine from back in 2008, has a second edition out, and Michelle and Bob did a project just recently together and wanted to share their fervor for public health behind bars. I'm not going to belabor this introduction any longer, and I'll turn it over to them after I tell you that we have another of these grand rounds next week. Usually it's every other week. It's going to continue every other week after next week, but we skipped 3 this time because I skipped past July 5th. I didn't think anybody would show up on July 5th. So I skipped past July 5th and I scheduled another meeting on top of this one next Wednesday. So you regulars show up next Wednesday, and we're going to have a really interesting speaker from Atlanta that Dr. Staples Horne arranged for us, and that I expect to be really, really good about essentially about equity in our healthcare and corrections and the ethics of that. CME, for any of you non-members, is available. Just ask for it. We do ask for a free will donation. I'll give you the link to make that donation if you wish for it. Please send me an email and I'll put my email in the chat room. And finally, don't forget the conference, September 9th to 11th, Salt Lake City. It's our big chance to show ourselves to be the professional organization that we are. And I expect and hope to see many of you there. Bob and Michelle.
All right. Thank you, Mike. It's exciting that we're here today to talk about, oh, hold on, I don't know why it's jumping. Heaven bless us for technology these days. Okay. For our topic of public health behind bars, and we're going to do this a little bit different. We're going to make this very interactive. I'm going to go over some basics and the objectives, and then we're going to sort of back up with the objectives and have some further discussion. So what we do know is what infects us affects all of us. So even any infection or anything that goes on infectious behind the bars will soon show up in a neighborhood close to all of us. And what we found out, even though we knew that we had these two systems in place forever, when COVID appeared on the scene, it really forced a collaboration between these two houses, between corrections and between public health, because people now realize that the walls did not contain the germs or did not contain COVID. So it really forced this collaboration to the point where we really never had it as successfully before. And I really don't want to lose that momentum that we had during that time. And that's why we wanted to bring this presentation to you to let you know that although COVID may not be an official emergency anymore, lurking around the corner is just another organism that may create havoc on all of our lives as COVID did. So if you look at the pandemics of the past, present, and future, you know, something as simple as measles and how infectious measles is, and how we start to see a rise in the number of cases because we sort of let our guards down and people stopped getting vaccinated and doing a lot of things that they needed to do in order to prevent the spread of infection. So anytime you have an organism or any type of pandemic, the identification of that organism is essential initially. And then mitigation practices And then finally, surveillance and containment are essential in order to prevent a future pandemic. So we talked about it, we put together 3 objectives for this talk. And the first one, let me see if I can move this out of the way, is to review the opportunities to improve the population health of justice involved people through community health collaborations. Our second objective, that now doesn't want to move, hold on. Okay, let's see. I don't know why it's not, oh, there we go. Sorry, just didn't hit the key hard enough. Our second objective is to describe the unique lessons of personal health care and public health opportunities in a focused clinical practice behind bars. And then our third objective is to understand the unique pressures of dual loyalty, the pressures to embrace loyalty to the institution, often beyond professional loyalty to practitioners. So we're gonna sort of pause and have some open discussion, but we're gonna go back and really tag each of those objectives to delve very closely into those particular topics. So we're going to go to our first objective, reviewing the opportunities to improve population health through community health collaborations. And I started out talking about COVID and how we're able to improve the health of a population just by identification, as we mentioned, mitigation, the surveillance, and really also the interventions that we made with vaccinations. So I'd like to open it up for Bob to jump in and start this discussion. And then we are not very formal during this workshop, so we really want you to jump in with comments and really share some experiences that you've had, which we've had a lot of them. I know I have with public health. We have 159 counties in Georgia, 25 facilities, and all of our health districts do not match our districts for our other agencies. So it was, I'm going to give you some horror stories later on. We're trying to coordinate that. But Bob, go ahead and jump in and make some comments.
Yeah, hi everyone. I'm thrilled to be here. I think we all learned a lot under a lot of pressure from the beginning of the COVID pandemic and right through now, where we still have COVID among us. What I'd like to talk about is, I don't want to go through a kind of banal medical student 101 discussion, but what were some of the challenges that you've had in your practices, in your agencies, and if you have any insight into how you breach those challenges to make progress. So I'd like to hear from all of you who had the biggest challenge and what did you do about it to make it better?
Hi, if I may start off, one of the challenges that I, as a surveyor, having visited hundreds of facilities.
Charles, tell us who you are.
I am Charles Lee. I'm the current president of the American College of Correctional Physicians. I was with the Department of Corrections in California for 10 years. I retired and I now exclusively do surveys of correctional facilities.
Thanks. So what did you find, Charles?
My concern, particularly in prisons, is that the introduction of COVID was not from the patients, but from the employees. And correctional officers are, with all due respect, breed of their own, and they had negative ideas about masks, about immunizations, and about being careful of spreading it. And that was one of my main concerns, was how COVID was introduced into prisons. Now, jails, as you know, is different. They come off the street and they can introduce it that way. But prisons is a different situation. I'd like to hear what you all think.
Yeah, and also, was anyone responsible for employee health, as I was? during COVID? Did any other physicians on the, or the other providers on the call? Did anyone else get involved in employee health? And I'll comment if no one else did. Okay, so I had, in addition to the 25 facilities and the 1,000 kid ADP, I had about 3,000 employees that were also being monitored by our agency for COVID. And also we got involved in the contact tracing with public health. So that was a huge project / nightmare in trying to get individuals' health information and protected health information back to public health. So what we ended up doing, we created just a limited number of individuals that of course had access to this data. And anything that was at a facility level has to have a HIPAA file at the facility level. But we were able to create a spreadsheet with all the information that public health needed for the employees. We did it for the kids as well, but it was actually a larger spreadsheet for the employees because we had way more cases among employees than we had among the youth in our facilities. But public health initially started calling, and I guess I told you we have 159 counties. So those health district folks kept calling individual facilities and just asking questions about, you know, people that had COVID infections. So of course, no one would tell them anything because we're corrections. We don't disclose any information to anybody, even if we weren't healthcare. So they were being stonewalled by the facility folks, and the public health people were really frantic to get their information. So this is how our central office ended up intervening and not having, you know, 50 people calling 25 facilities trying to get information. So we funneled everything in through central office, involved our HR department and our security administration and our, you know, me with healthcare to try to get a system in place where there was a one-stop shop to be able to report that information back to public health so they could do their contact tracing. So did anyone else have to get involved with employee health?
No.
Yeah, hi, Dr. Fritz Vore. We were lucky up in Maine because Maine, in Portland, Maine, as opposed to Portland where you guys are.
I am.
Maine is a small town, one big small town. And we developed a very intimate relationship with the CDC in Maine, who sent a fellow down and was on the phone with us daily. And we had a lot of employees, especially correctional officers, who were opposed to vaccination and opposed to getting tested. We put an automatic testing device with a station with a person in the lobby. You couldn't come in without getting tested. You had to fill out questionnaires. We got the Westbrook, Maine Fire Department to come over and help vaccinate folks for us. So that's the kind of luxury you have in a small town setting.
And was that successful? How successful were you against the people who were so, I would say, ridiculous about resisting?
I would say we were about 50% successful.
Well,
The
that's
sheriff's very
that's-
well liked, and he didn't mandate he didn't really holler at everybody a lot, but he kind of said, come on, guys, put it together, get vaccinated, come on in here. If you're sick, stay home. And it worked out pretty well. We had 57 COVIDs out of a population of about 350. We closed the jail except for very serious folks that needed to come in. And we isolated everybody who had COVID for 14 days.
So how did you feel about the 50%? Did you feel that was a success or a failure?
Well, I didn't feel it was a success, but I'm told it was a pretty good success.
Uh-huh. Anybody else?
Yeah.
Anybody
so
else?
this is
How did
Dr. Wu
you
from-
do?
Sorry, Bob.
Go ahead,
Go ahead.
Johnny. Johnny, tell us. You've got practices all over the country.
Yeah, so that was a big challenge for us at Centurion Health. So, we're in multiple states and dealing with multiple jurisdictions and agencies. And yeah, since the beginning of COVID, there's no guidelines. There's nothing really, no playbook other than just regular infectious disease policies that we had in place, around like, say, like a pandemic flu outbreak. But it was challenging times to get real-time information out to the staff, try to rile people up to take vaccine when vaccines became available. But I think unfortunately I felt a little bit down in the fact that a lot of the advocacy groups out there were like constantly hounding us on the poor management but we actually found that our number of folks who got infected with COVID, it wasn't really due to race. It was actually people who actually were Afro-American were actually doing better. It was really more age related, and if they were immunocompromised, that was more of a bigger risk factor that we saw. And then with our employees, we ended up with just under 1,000 employees that ended up with COVID. And we had 14 deaths, but I wouldn't say all 14 deaths during that time were due strictly directly to COVID. So, I mean, we think it might have some play into it, but we'll never know for sure. But and we had at that time just a little bit over 10,000 employees working.
Johnny, any lessons learned? You not for I know that you knew what to do. But do you think there is any change among your 10,000 employees in saying, oh yeah, here's what we have to do. Here's how we have to work together. Here's how we have to cooperate with public health departments. Do you think there was any enlightenment there?
I think for the great majority, they were appreciative of the fact that we tried to be transparent as much as possible with what we knew. So we had regular town halls where we'd have like 400 or 600 employees at a time participate, listening in to getting updates on a weekly basis. So that helped with morale and also having them look out for one another. We kept talking about wellness, mental health early on, which I think was a big help for us. But in terms of the vaccine uptake, when that became available, that was truly difficult. People were just so, in their politics. And when, the mandation and then whether that applied to us, I mean, we said that we, should do that. And our parent company at the time encouraged us to do that. But then it was a struggle where we actually had to ease up and not mandate it. But if they didn't take the vaccine, they would have to undergo weekly testing. So that was kind of the trade-off, and which ended up being okay, because again, like I said, I think we came out as pretty well with only, one death is bad enough. But I mean, I think, out of 10,000 and you have like, 14 or 15, that I think we did pretty well despite the odds.
Yeah, anybody else dealing with this tragedy of deaths, whether the numbers be small proportions like 14 out of 10,000, but still 14 people dead?
Yeah, and Johnny, you also brought up a good point about vaccine hesitancy and the whole politics around vaccination, because in a lot of states, you could not mandate vaccination. In some states, you could not mandate mask wearing. So I'd be interested to hear what other folks also may have heard with the, or how they've dealt with the politics of COVID as well.
I'll just say, I'll just be brief. I worked with a mid-sized to large East Coast urban jail, and they had at a baseline, they had a very good relationship with the local health authorities, with the health department authorities, and they did very well through COVID because they had their ducks in a row. And I think if one thing that we learned through COVID, it's how to interact more with our local health authorities. But I think their success in this one jail system was very much attributed to how well they were in contact with the local health authorities beforehand.
Thank you, Mike and Johnny. So let's transition a little bit to some of the other major public health challenges that we have that don't get the press that COVID have, that don't get, for some reason, the urgency, although there are more deaths. Let's talk about addiction and overdoses and addiction treatment. Are there any similarities? Is there anything we learned from COVID that we can apply to dealing with the matters of addiction in our practices? Who's here who has had some challenges and successes? There must be somebody. I know we've all had the challenges.
Well, I'm going to say up in Maine, we have 40% of the jail on a MET program now, and that's good. And we have increased counseling and all of that. But
where are you? Who are you, and where are you?
I'm Fritz Vore, Dr. Vore, Fred Vore, and I'm the medical director up in Portland, Maine,
Gotcha.
which is a small place. One of the nice things is that much of the jail staff also knows much of the community staff, and so the folks that come in are often folks that are known to us from outside, and we've done pretty well with increasing our public health information about COVID. We have about opioid use, substance use disorder. The Governor Mills is very much on our side. She's actually next Thursday having a big statewide summit in Portland about substance use disorder and opioids. So it's getting a lot of news in the local news.
And you've got the latitude to use medication-assisted therapy and the funding to do that?
We do, thank God.
Wonderful, thank
Wow.
God. Yeah,
Lots of-
who's here who's having frustrations making that happen?
I find it hard to believe that nobody's having frustrations with this.
Nobody wants to talk about it.
Well, it's all right.
Well, I don't know if I'm still muted. I guess I'm not muted, but I have to tell you, everybody who leaves has a little bag with fentanyl test strips in it, Narcan in it, instructions about how to use it in it, instructions how to tell your friends to stop using drugs and don't hang out with people who do, and a list of local recovery houses that will come and pick you up if you need a ride. So I think we're making some progress.
Well, kudos to you. It's
Yes.
That's
Not
terrific.
me. I have a habit of taking credit for things I don't do. But
Well,
the
you can take credit. You're a real public health doctor.
local community folks are on board, so that's nice.
Well,
You know,
that's great.
this is Charles again. Speaking of curious experiences, I was at one jail and there was a vending machine in the lobby in which it was free. You just pull the knob and out comes the Narcan. And it was used. It was used by visitors. It was used by people like on Uber who dropped people off. They would come in and get a packet. It had 2 Narcan kits within it. And I thought that was a wonderful innovation to have free Narcan in the lobby and a vending machine.
Charles, can
It
you
was fun.
tell us
I'm sorry.
where
Yeah.
that was, or is that you need
That's
to
in
keep it
LA
private?
prison.
It was a jail, and it might have been in Oregon. I'm not sure. You know, I've been to a lot of jails and I really get them mixed up. But
Sure,
I
from the Philly prison
think it
system.
was Oregon in a jail, in a vending machine. And, you know, just for the sake of it, I wanted to test it. So I pulled the knob and down it came, a Narcan kit.
I wonder who was funding that. Was it the jail?
I understand Kentucky right now has vending machines. I learned that today through the AIDS education today, that they have vending machines that are free and stationed in several places. And the first day they put them in, within minutes, everything was gone. So they have to keep on stocking it. And I think it comes from the funding through the substance abuse disorder, substance abuse funding from the legislature. No, from the legislature.
Samhsa.
Yeah.
I can tell you that the same thing is happening in Philadelphia. Last I heard, they were working to get vending machines in place and that they got a grant. And I'm thinking they told me it was from SAMHSA, but I'm not sure. And I can follow up and find out where they got their grant for that project if anybody is interested.
You know, a challenge that I experienced, I was at another facility and there was a jail and the officers were not allowed to have Narcan. And I've been to other facilities in which all of the officers had Narcan. And the reason that the officers at the place that could not have it is that they were afraid, or administration or the people in charge were afraid that they may overdose them with Narcan. And I tried to explain that that ain't happening and that it's a safe drug. I put drug in quotes, but the sheriff and his people, the warden said no, they would have to wait. If there was an issue, contact medical because medical had the Narcan, but the officers could not have it.
Charles, that's a great point. And that moves us into one of the major ethical dilemmas in correctional healthcare that's really a public health issue, and that's the matter of dual loyalty. Who's in charge when there are medical or public health issues? How do we react to reactionary visions or views of what should be done? Everything from we don't want to give opiates to opiate abusers because that's feeding the problem, to we don't believe in masks, we don't believe in forcing immunization on employees, we don't want to give our patients autonomy when we say it's up to them if they want to eat or not eat, when we're ordered to force feed people. Who's had experiences with these very difficult challenges of loyalty to our profession, our patients, and our medical ethics versus loyalty to the institution who may be asking us to do something very different? Is that too big a stretch from what we were talking about? I don't think so, but tell me what you think.
At the risk of saying too much, I have found that it all depends on the relationship between either the sheriff or the person in charge and medical. When I was in the correctional facility at the prison, I had a wonderful relationship with the warden. He was ex-Marine, I was ex-Navy, so you can imagine how that went. But it was joking, it was fun. We got together and he put medical in my hands and he did not interfere other than safety and security. We know safety and security is number one, but absent that, medicine was mine. And he even assigned a captain, a correctional captain to medical. And anytime I had a problem getting a patient to sick call, I would go to the captain, and before I could get back to my office, the job was done and the patients were down where they belong. So that's very important, developing that relationship as to who's the captain of which ship.
And that brings up the issue of medical autonomy as well, because we know that can be a sticky subject at times in our settings, but we have to maintain medical autonomy. And in situations, what I've basically tried to do is really create a medical autonomy policy so that when there is this dispute, which is bound to happen, at a local facility, a local level, between, say, security and medical, that there is a process, a defined and written process of how that goes up the chain and ultimately ends up to me to get that resolved. If you don't have that in place, then you'll get a lot of squabbling that may occur at a local level with no ability to resolve it. And then you have the patient there that ultimately may suffer because no one is able to make a decision. So I think it's important to include the medical autonomy in this discussion as we talk about loyalty to the institution and also loyalty to our profession.
So who's been challenged by that, and how did you deal with it? Who else? Dr. Lee has been very successful with the warden of his facility, but who's had, encountered a little disagreement, and how did you deal with it?
Other than me. Who else?
Other than Michelle, but she prevails wherever she goes.
I'll just live longer in the position than all of them. So
I got a couple of stories from New Jersey from the 1980s. If that's not too old a story to tell.
oh
Tell us,
yeah,
Dave.
I want to hear it.
Tell us.
So I'm a young communicable disease control officer for the New Jersey Department of Health. And my boss sends me up for a tuberculosis outbreak at Rahway State Prison. And I walk in and say, can you give me a list of who's in what bunk on what nights? And the answer I got is, we do not keep those records. Why would we ever think about keeping those records? Don't you realize that we're about something else here? And I'm thinking, if your job isn't to keep track of people, what in the world is your job? But I wasn't going to win that argument with them on that.
Let me interject. Here's another answer you might have had the presence of mind to say, is if you can't count in prison, you don't have a prison. Keeping
I had
count.
a number of thoughts about them, and ultimately they wound up asking the folks in Trenton, can you please send us another communicable disease investigator?
So how did you deal with that, Dave?
By continuing to uphold professional standards until I was thrown out. My observation was, in that particular place, the officers on the cell blocks were the sanest people in the institution. The second sanest were the inmates, and the most difficult were the administrators. But then I walked into, a few months later, I got sent to another TB outbreak in South Jersey. And I guess the boss hadn't lost confidence in me. And I walked into that one and they gave me everything I wanted, said, you do what you need to. We want to stop this from happening in our facility. And it was a pleasant experience from start to finish.
So how do you think you could translate that to the first facility you were in where they were antagonistic and threw you out?
I am not sure. They were pretty focused on what they thought was good for them, and I was young enough to not be able to roll with resistance, as they say in motivational interviewing. And looks like Mike has some ideas.
Go ahead, Mike.
I don't want to interrupt you, Dave. My thought is that it's all about being patient and developing trust, and I think that's really what served me in my 20 years in the same institution. I mean, the first month I was in the building as the chief medical officer, I tried to contact the security officer about an issue, and frankly, I can't even remember what the issue was. It was over 25 years ago, but it was clear that he was in his office, the door was closed, and he would not answer his door to me. And he wouldn't answer the phone to me, and he didn't want to talk to me, period, end of story. I was an outsider, I did not belong, and I thought, oh my God, what am I getting myself into? And the bottom line on the ethics is we have to keep pursuing it. I got lucky, they changed security managers. I think he didn't want to deal with me because he was a short timer. I didn't know that. But shortly thereafter, there was a new security manager who answered his phone and answered his door, and who was skeptical of me, but eventually we developed trust, and that's my experience.
How do you do that, Mike? We all encounter very difficult people. We think we're being rational. We think they're not rational, and they put up their defenses and they say, no, no, no. And I remember this wonderful book about negotiation called How Do You Get to Yes? So how do you deal with that? I was called in to a county in the northern Midwest some years ago where they had an outbreak of tuberculosis. And I was called in as a consultant in a jail, county jail. And there was a little reluctance, but I was asked to come. And I went up and I asked first to tour the facility. The first thing I didn't even want to know how many cases and who was infected and all that. I said, give me a tour. We walked through the facility, seemed to be pretty well managed, except I walked into one housing unit where the temperature was 10 degrees higher than any other housing unit. And it smelled bad. It smelled rank. And then I went and I asked them, okay, so where are your cases of TB? They all came out of that housing unit. And then I said, so how's your ventilation? Have you looked at the HVAC in that housing unit? And they said, it's all fine, doc. Don't you worry about that. You're a doctor. I said, no, I insist that you check the ventilation. And it took presenting the data on the failure of they had no return air in that facility, and the cooling unit wasn't working. It was summer. And so they were infecting people. So what was it that I did to get them to change their minds? I told the president of the union of the risk to the officers on that housing unit.
Yeah.
And the officer said, oh my God.
Yeah. That things go between the fence and the into the community, and that sometimes that's Bob, that's a gold card to get folks to understand that you're bringing these things home to your family. It's not just going to stay in the jail. And I think the other thing that's important is to really try to develop these relationships with security and with public health before there's a crisis. That helped me tremendously because I already knew the health commissioner, the commissioners of the agencies, et cetera. And when you have some time to develop trust prior to the crisis, then when the crisis does occur, then you can easily pick up the phone, and people are much more cooperative because then they don't have those walls up that they may have had and see you more as an outsider trying to come in.
So who's had failures in this regard? Michelle, Michelle, you're so good at what you do, but not everybody is as effective as you and has people who've been as cooperative with you as they could be. Who's had failures, and what are your ideas about some of this?
So, I mean, we've all had successes and failures. I mean, I think I developed pretty good rapport, even because I went through the cadet training, that the cadets who trained with me were very understanding of what medical does, and they always knew I had their back. But there are times where, there's no way to reason with people because out of greed and spite and protecting of their positions, that you just can't overcome, unfortunately. And because I've been kicked out of a lot of places, but
And
it,
everybody who's been kicked out of facilities, raise your hand.
Well, not let in. How about that? When
Well,
I
that's
first
the
started,
same-
they wouldn't let me
That's
in.
the same thing, or locked into the Sally port.
Yeah. Well,
Oh.
the other thing is when you say success for me, I mean, one of my failures, of course, when this initiated, particularly around COVID, I had a mask mandate, but then we received direction from above that we could not mandate masks. So I was not able to follow my medical judgment, but had to sway to the politics of the day.
But I think one of the problems I had as a young health administrator was that I came to the problems, had more knowledge about the problem than the warden that I was dealing with. And so young as I was, arrogant, you come to that, and we still do. We come to the problem with more knowledge about what we are talking about than the people we are talking to. And sometimes they don't want to feel belittled by our knowledge. And so they put up a fence. I had an incident at one of my prisons where I was working. I was the health administrator. Of course, I was the dentist and health administrator. And my OBGYN came to me that she needed condoms to go over examination kit for vaginal examination because they were plastic. And they will cut, it's very painful if it's not during the examination. And here comes the warden to my office, throwing the chairs everywhere. And I was a little bit upset about it. The only thing that saved me was asking him if he had ever gone to the examination room with his wife. He never had that. And that was the end of it. And we had the condoms for them to use. And nobody had used the condom illegally since then, up to today, and I'm not on wood. But I was coming in, I saw the problem, and I thought that this should be no question. And that's sometimes the challenge is, as I get older and gray, I think I'm learning to just be quiet, listen to them, have them present their positions, and then negotiate and talk with them.
Well, go ahead. I think it's so important not to pontificate, and to the administration side and tell them, well, you know everything that's going on, because they'll put up a defense right away. And knowledge is there's a lot of knowledge that's not known to a lot of folks. We just had a fellow with shingles that had broad shingles across his chest.
Where was this?
Up in Portland, Maine.
In Portland, okay.
And sure enough, 2 weeks later, his cellmate gets, and we had separated them. We had separated him out. He gets chickenpox, and he was from Africa. He only spoke Lingala, and I got a call in the middle of the night that he had chickenpox. And I said to the nurse, "Are you sure it's chickenpox?" She said, "I know absolutely what chickenpox is. I had 2 kids with chickenpox. He's got chickenpox." Well, that got in the newspaper in Portland that there's a chickenpox outbreak in the jail, which was kind of fun. And but still, there were a lot of people on the correctional side and a lot of inmates who had no idea about what shingles was about, how it was caused, about sleeping chickenpox virus in your body that came out as shingles later, and that was in fact contagious. So we had a lot of education going around that was pretty well accepted, and fortunately we got clear of, we isolated a lot of people, and we identified those who thought they had never been vaccinated against chickenpox, and we got a lot of staff and inmates vaccinated.
Did you have any trouble getting vaccines?
Oh, no, the CDC in Maine is fabulous. They said, we'll be down tomorrow with our nurses and with the vaccine. So, I mean, you can't ask for more than that.
That's great.
Yeah. Alma, did you have your hand up?
No, I was just going to share my experience. That's all. I just feel, yeah, well, when Bob, I think it was Bob who said mutual respect instead of coming out loud and trying to educate, belittling them for not knowing. I'm lucky. I'm the medical director at DuPage County Jail, which is the second largest jail in Illinois. We're right next to Cook County, which is the county of Chicago. I haven't had any problems with custody, with the administration. The sheriff is open to our requests. I should qualify that. Requests regarding medical needs of the inmates. Staffing is a different issue. You know, when people ask for raises and all that, that's a different issue. Or ask for, I needed, whenever I needed, but of course my requests were also reasonable. You know, I never asked for an during COVID, they were all worried. They were acting independent of medicine. They didn't think we were doing anything. I was fortunate enough to get in touch with the Illinois Department of Public Health and was able to acquire the COVID test kits, about 300 of them for all our inmates. And unknown to me, they were trying to acquire COVID test kits from a private agency. They had to buy it. And I think it was very expensive. And I got my test kits for free from IDPH. And then, that was and then it was difficult because their test kits, so we did a study, we compared their test kits with our test kits. It wasn't so much the effectivity, but the logistics. After we swabbed, after we used their test kits, we had to mail it to go to Texas. And then we had to wait about 3 to 5 days for the results. Whereas the test kits that I acquired care of the Illinois Department of Public Health, which were free, we got the results in 1 to 3 days. And so since then, they had a renewed respect, I think, for medical and for me. So we never butted heads. They always supported me. I can't think of any example. Like when COVID had a problem, when we had a problem with COVID, we never had a problem with COVID. We never had a death.
Alma, you're doing an incredible job. You've got an incredible leader as a sheriff, and you've been really effective. And it sounds like we have to reproduce that relationship across the country.
Yeah, I hope so. And I don't just work for DuPage County Jail. I worked for a group, Advanced Correctional Health, and they served small rural jails in Illinois. So I was like the main doctor for all those jails. Some of them I got thrown out when I answered the phone.
Well, I think most of us had our hands up when I asked the question. I think it's a badge of honor. I was in Mobile, Alabama.
Oh, that's where my in-laws live.
For the Justice Department a long time ago, probably 25 years ago. And DOJ, I was there on DOJ visit, and I got thrown out of the jail there. And I was very embarrassed. I was humiliated. And I called the senior attorney in DC and said, I just got thrown out of the jail. And she said, I'm so proud of you.
Congratulations.
I learned a real lesson. Yep.
That must have been early on in your career. Yeah.
Yes, it was early on in my consulting career. Yep.
Yeah.
Yeah.
So I have a question for folks as we talk more about public health. What were any of you able to get public health nurses to come into the facility to provide vaccination or testing, or did they just provide support? Mike.
So I have a question for the group. And this came out of one of my experiences in California at a jail. And they had a public health nurse from the public health department, the city public health department, maybe the county. And she was at their CQI meeting. She was an invited guest at their CQI meeting as an outside participant. So not exactly answering your question. And I will say that there were in Philadelphia, there was a lot of involvement from the public health people coming in and doing work and like that. And that was because of their already established relationship. My question is this: at that meeting, it felt to me as an outside observer, I was an outside observer consulting. And I felt like they were more or less ignored whenever they gave input into cases or situations. And I guess I'm wondering how I can do a better job of encouraging them to listen to the public health sector at their meeting. It was a very challenging situation for me. I was new and I didn't know anything much. And I wonder if you have any advice for me, anybody in the room. How do you interact in a positive way? How do you encourage others to interact in a positive way with public health officials who are participating in your care?
Thanks, Mike. Mike, that's a really good question. And I just looked at the chats for the first time, and it sounds like, Dave, you have something to offer that responds to that could be helpful to all of us.
Which one?
Which one? Well, in your first correctional assignment.
Okay, so it's now the
No, I take it back. I take it back. Wait a minute. It's your last one. Successful navigation of dual loyalty.
So after I got to Washington State, I got a little bit of a reputation with Mark Stern, who many of you know, as a pretty decent troubleshooter. He sent me to a couple of places as his acting medical director when he had some leadership vacancies to work with. And then one day he called me and said, I got this situation at one of my prisons. We just had the main provider, who was a physician assistant, who came in and immediately started addressing all of the inmates as my friend and signing every medical exception that was requested of him. Sneakers, no problem. Lower bunk, easy. Excused from this assignment, that assignment. Mark said, we had to walk the guy off. But now we got a mess to clean up. You up for that? And the thing I was able to do, and this I came in as a clinical cleanup, not as public health, but I was smart enough by that time to ask for a sergeant or some leader of correctional officers and ask, what I'd like you to do is to give me a list of everything you've got doubts about, with the stuff that drives you craziest at the top of the list and the stuff that drives you the least crazy at the bottom of the list. And I'll work it as quickly and fairly as I can so that the good excuses get honored and the bad ones get reversed. And she had that list for me in about an hour.
Wow.
And Dave, did that work?
I then went down it and took care of each of the inmates, saying, for the vast majority of them, I really wish I could say yes to this one, but I can't. And the most common reaction was, yeah, doc, I knew this was coming anyway. So within about 3 days, I had happy sergeants, reasonably content inmates, and job mostly done.
Kudos,
There's dual loyalty once I figured it out.
kudos to you. Great job.
Yes.
Michelle, do you want to wrap up?
Yeah, sure. I just want to reiterate that having that relationship with public health before the crisis is really essential. I've worn a couple of hats. I actually worked for public health, which also helped in my correctional role. So when things we had relationships up front. And one thing I'll tell you, if you can find the carrot that benefits both parties. For example, the Fulton County Health Department, they were having trouble meeting their immunization numbers for kids. I have kids, so we have the free immunization program. And so they were having trouble getting their numbers up. Well, guess what? I have lots of kids that need shots. So they were actually willing to come into the facility and provide and bring their own nurses in and provide immunizations for the kids, as long as I would let them count the numbers on their end and meet their quota. So there was a carrot that sort of made both folks happy. So if you can find that common ground between corrections and public health, then I think it goes a long way in really solidifying that relationship. So I think we're probably almost out of town. Did we get everything out of the chat, Bob and Mike?
I think so. There was a little bit of discussion about whether Narcan suppresses pain or not, if people get to having pain after a dose of Narcan, but I don't think that that's essential to this discussion. I
didn't say it suppressed pain. I said it recreates pain in somebody who's taking opioids in response to pain. You Narcan those folks, they'll get their pain back and they won't be happy.
Yeah, it does.
Yeah, they won't be happy, but they'll be alive.
Yeah,
that was my response to Charles's early one about.
Okay.
So I think we also need to look at, what is the purpose of Narcan, naloxone? Is it really to completely reverse or just to restart or resume their breathing, rescue breathing?
Yeah, right, that's it.
So you don't need to give it so that they go into withdrawal. You just need to give it so they breathe again.
Breathe.
Yeah, if we can get breathing back, that's fine. Although I don't know very many people who are getting exactly where they want without overshooting.
Yeah, there's a certain amount.
Well, that's
Well,
because
Maybe we'll do one.
Narcan is better by the higher dose.
Yeah.
Maybe.
But isn't more better than less?
Depends.
Not always.
Less is death.
Less than you need is potential death. More than you need is waking up in full withdrawal for people who are dependent on the full opioid. And the folks who wake up in full withdrawal, the first thing they want to know is, how can I get out of this ambulance? How can I get out of this emergency room? How can I get back to my stash? And that's one reason why repeat overdoses are so common.
Maybe we should do a session on Narcan and treatment, on another Wednesday night, because it sounds like we've got a lot of discussion that we could continue for a while.
I'm sure you got a whole lot of good correctionists, addictionists out there. I'm more of an addictionist than I'm a correctionist, but I'm happy to help any way I can.
That'd be great, Dave. We'll be calling.
You'll be, that's right. You count on it, Dave. Not necessarily at the September conference, which is already scheduled, but I just want to thank everybody, and particularly, of course, Bob and Michelle, my friends. Thank you so much. I've on behalf of the rest of the group, I really appreciate this. I think that this is by far the most participation from the audience that we've had in one of these, and something that I've always looked forward to, being able to encourage audience participation. Somebody's trying to get and by the way, there's a message in here from Ray Patterson, and I am just so happy to hear from Ray Patterson. Are you the Ray Patterson that I met in Philadelphia?
He's
I certainly am, Mike. Thank you very
Oh
much.
my gosh, I am so happy to see you again.
Thank you.
And I'm so happy to see you here. I appreciate your attending this, and I hope that you'll encourage your colleagues to do so as well. It's
Absolutely.
nice
Thank
to see you.
And I
Would
just
you like
wanna-
to ask a question? We're going over a little bit, but I don't think that's going to harm anybody. And if you
Well,
want to
I'll
sign off, folks.
I'll be very brief. I have been so enthralled by this discussion. I really have. And I too, I want to join in thanking Bob and Michelle in leading this and the participants. Your experiences are terrific and sharing how you deal with this. But of course, I'm a psychiatrist and I'm interested in how much mental health staff have been involved in your negotiations with corrections when you're running into these brick walls. Are they with you? Are they someplace else? Or does it vary? And I really am concerned that we're all medical, even though you guys are medical lead, et cetera. If mental health isn't supporting you, that's a problem. And that's why I'm asking the question.
Dr. Patterson, it's great to see you and
Yes.
great to hear from you. What a thrill.
Thank you.
And I think you're bringing up the matter of the silos between mental health and medical. And it's really important for us probably to vote a whole grand rounds on how to reduce those silos, how to have multidisciplinary care, but also how to have multidisciplinary relationship building with custody and politicians.
Yeah.
Yep.
And I think we probably do better because I have kids with multidisciplinary teams, because we have to have education and medical and behavioral health and security when we all meet to discuss the kids, with the behaviors and the other challenges. And then we have also a mechanism in place that if a kid is wreaking havoc on the security end, they can refer them to our panel, and our panel has medical and behavioral health on that panel to try to come up with solutions to involve security to better manage that kid. So we probably do more of that, I think, probably on a routine basis than the adults may. But that's just an assumption because I've always been with kids all along.
I'll just say that and just to change the subject and try to wrap up, anybody else? I'll say that Steve Shelton is speaking soon in this forum about ethics, and I have talked him into it, and he will be here. And that's in the near term, and that's a lot of what we're talking about around silos, around interdisciplinary care, et cetera. And is directly what you're talking about when you have a conflict of interest within the institution. So I'll say that. Michelle, would you like to say something about Dr. Wimberly, who will be speaking next week?
Sure. Dr. Wimberly is an adolescent medicine specialist, but she most recently was appointed the director of the Health Equity and Inclusion Office at our major hospital, Grady Memorial Hospital here in Atlanta. And so she is leading the effort for that hospital on health equity and diversity. And so I've asked her to present to us on next Wednesday. Really just talk more of a general health equity discussion, but with a correctional slant, because I know that we had not included any of that in our along our series. And I think it's particularly important now to include that because it is a very hot topic. Let me just say it like that. So she is going to be presenting on next Wednesday, and hopefully we'll have as many people that were able to join us today, and maybe even more. So really appreciate the participation by everyone. I hope this has been a fun event. We want to make it sort of interactive and keep you all awake this late in the evening.
spread the word, and I really appreciate everybody's participation. And I think that we'll sign it off unless somebody has something else to announce or something else to say. Appreciate you all. Thanks. This has been fun. Appreciate you.
All right.
Good
Bye.
night.
Bye-bye now.
Bye.
Hey, everyone.
Bye.
Take care.